All right, everyone, we're going to go ahead and get started. Thank you all so much for joining us this evening for day 4 of our conference, Moving Forward, Advancing Equity in Public Health. I want to say thank you for all of our presenters today. We're really looking forward to hearing about your work as well as learning ways and methods that we as future public health professionals can impact change and health equity in the public health system. So without further ado, let us jump in. So just a quick overview for today. We're going to have 3 presentations that we will be having. The first is Advancing Equity in Healthcare by Improving Access to Primary Care. The presenter for that would be Muna Ali. And then the second presentation will be Por Nuestra Salud y Bienestar, Reaching the Hispanic Community in Times of Crisis, which will be presented by Dr. Ana Maria Izquierdo Porrera. And then our final presentation will be by our PHSO member, Jalesia Green, and she'll be presenting on Moving Forward, Advancing Equity in Public Health. So without further ado, I will turn it over to Muna.
Hi there. Can you guys all hear me?
Yes.
Yeah, good afternoon or good day. My name is Mona Ali. Today, I'm going to talk about how we can improve access to primary care, will increase and advance equity within health. Next slide, please. The agenda for the next 5 to 10 minutes that we have is a little bit about my background and why I'm passionate about primary care. And if we want to re-envision the current primary care, what is our initiative strategy and what should be our goal? And we'll have a Q&A time too. So a little bit about me. My name is Mona Ali, as I said. I'm a healthcare management consultant and a clinical implementation specialist. I'm passionate about providing solution-focused and outcome-based nursing care. My core experience is in service model rollout and program development. In the past, I have partnered with various interdisciplinary teams to address the delivery of population-focused services and intervention, which provide continuous, equitable, and holistic health. I'm a proud BNU alumni. I graduated October of 2020 with Masters of Public Health and Certificate in Management and Health Policy. Regarding equity, to address the COVID-19 health disparity, we must rethink the way we deliver healthcare and shift from being reactive to being proactive. Therefore, healthcare services must be consistent, sustainable, and innovative. We cannot achieve that, but we can achieve that by increasing access to primary care services, especially to marginalized groups, to reduce disparity. It's not a surprise that the pandemic has negatively impacted vulnerable communities. There is significant differences between the experience of groups that have experienced advantages and the experience of marginalized groups that have experienced disadvantages. A recent study from the primary care collaborative study have surveyed some counties, and they found individuals that reside in that have a robust primary care, public health, and social assets. Their residents were 42% less likely to die from COVID-19. Currently, there is 38 million Americans that live in a primary care desert. The majority of them live in a rural America and or belong to a minority group. Next slide, please. So according to the American Medical Association, they indicated there's 5 strategic approaches to tackling barriers to addressing primary care services. First is embed equities and racial justice. That can be done by expanding capacity for understanding and implementing anti-racial equity strategy via practices, programming, and policies. Second is building alliances with the marginalized physicians and other stakeholders through developing structured and coalitions to elevate the experience of ideas of historically marginalized healthcare leaders. Third is to push upstream to address all the determinant of health and root causes of inequality by strengthening, empowering, and equipping physicians with the knowledge and the tools for dismantling structural and social drivers of health inequalities. Fourth is ensuring equitable structures and opportunities in innovation through embedding and advancing racial justice and health equities with an effort to promote digital health. Five and last is foster pathway for truth, racial healing, reconciliation, and transformation by accounting for how policies and procedures excluded, discriminated, and harmed communities, and by amplifying and integrating the narrative of historically marginalized patients and physicians. Next slide, please. The goal of any primary care program should be focused on building public health infrastructure, and it should be improving access to affordable, equitable health, and that can be done through the telehealth flexibility, specifically for population that reside in rural area or lack transportation if they live in a marginalized community. So we've seen how telehealth took off during the pandemic. Second thing is health equity centered policy. And that's where we come in as a professional public health advocates. We can, during the pandemic, I've sat in multiple tables where I advocated from the lens of the experience of my group and my population. So being present on those tables and advocating for public health. Third is a mental health and substance use treatment that is trauma informed. Last but not least is any primary care program should be focusing on ending maternal maternal morbidity and mortality. Yeah, that's it for me today. You guys have any questions?
Thank you so much, Mona. Like she said, if you have any questions, you can unmute yourself or you can feel free to type them in the chat.
Since we don't have questions, I'm just going to talk about one of my experiences when I was working as a coordinator with the COVID-19 team. I was collaborating to implement immunizations and COVID-19 policies that prevent the spread of COVID-19, mainly in corrections and also in farms. So we had an outbreak in one of the corrections, and the reason, everyone was scratching their head, trying to figure out, hey, the inmates are not coming close to each other. How come the COVID was spreading like wildfire? And I suggested maybe it's the ventilation. And that's just because we've taken a course that talks about how ventilation impacts our vulnerable population. Either they reside in a correction or they reside in a rundown home. So it's the same concept. Yeah, that's about it for me.
Thank you so much. Thank you for sharing about your experiences as well as ways that we can advance equity in primary care. I know that was something that was very eye-opening for me. Moving right along, we are going to go to our next presentation. I'm going to turn it over to Dr. Izquierdo Pereira.
Thank you. Can you hear me?
Yes.
Perfect. So my presentation is a little bit more practical. So you got the framework of equity, and now I'm going to give you an example of how can we apply this framework to the day-to-day, right? So, oops, can you, next slide? So for about 20 years, I've been part of the Latino Health Steering Committee. And it was founded in the year 2000. I became part of it in the year 2004. And we generally spend a lot of time looking at system design and advocating for changes within the infrastructure of the county that will support Latinos. The whole Latino Health Initiative is composed by the staff of the initiative, the steering committee, which is a group of volunteers that advocates for the well-being of Latinos in the county, which, by the way, is Montgomery County in Maryland, and then a group of health promoters who are in the street educating and helping. So 20 years of us trying to tell people how we need to deliver care for Latinos. And actually, if you're interested in reading a little bit more, I put the link of the blueprint. This is the last blueprint we issued. There have been 2 blueprints earlier. And it was sort of the guiding document that we used to sort of advocate for what changes needed to happen. Next. So then the pandemic came. We were doing our own thing, trying to take care of our community as best we could, and the pandemic came. And around June, at the end of June or the beginning of July, we got called, the steering committee of the Latino Health, we got called into a meeting by the 2 Latino council members in Montgomery County, Nancy Navarro and Gabriel Albornoz. And they showed us this data, and they said, we're getting sicker. This is the prevalence of COVID within the community, right? And although the African American community was dying more, we were just getting so much sicker than the rest of the members of our community. So these 2 council members said, you know, the county health response is not helping our community, clearly. Design something and we'll make it happen. So over a weekend, we designed Por Nuestra Salud y Bienestar. And people are like, oh, wow, over a weekend. And I generally say, a weekend and 20 years, because this was really built on 20 years of partnering and working together towards the improvement of the health of the community. So then we got the county executive, and Dr. Crowell is the head of the Department of Health and Human Services involved. It got funded. Also, our sister initiatives, the African American Health Program and the Asian Health Initiative, also got funding, and we all were allowed to design a response that met the needs of the community we serve. Next. So first thing in the design is that there was no one person or one group that was the main group. This was a public-private partnership. Proyecto Salud is an organization that has clinics for Latinos in the community. The county was a partner. CASA is an advocacy group that has worked on things from tenant rights, access to healthcare. They don't deliver healthcare directly, but they advocate and they support health services. Identity is a youth organization that works on mental health and development of youth in the county. Mansfield Clinic is a clinic that has served mostly Latinos in the community, primary care. The LHI I already explained, and Mary Center is a maternal infantile organization, also does primary care, and they're an FQHC. And then my organization, which is Care for Your Health, which we are actually a senior care organization. We take care of people in the community, and our mission is to help people age in place and stay home. So first, we had a big set of partners that came together in the weekend and designed this. The next. We did not design something that was like, oh, how do we go and vaccinate in the community, right? How do we go and do testing? Because one of the things that was happening in the beginning, I don't know if you're aware of this, is that at least in Maryland, in order to get tested, you needed an order from a doctor. But what happened to those that didn't have access to primary care, those that didn't have a pre-existing relationship with a doctor? They couldn't get the order. The other thing that we were seeing is that in order to get booked to do a test in the very beginning of the pandemic, you had to have a computer so that you can get booked. You could not call and make the appointment. You had to have a computer. So, how did we design a testing environment where people didn't need computer, people didn't need cars, people didn't need primary care doctors? They could just get tested. Eventually, we would think about the same elements in terms of vaccination, right? How do we go into the community? How do we go into the malls and the apartment complexes and the supermarkets and the trailer parks? So that was part of the clinical. We also designed a hospital at home. I don't know if you guys are aware of a little bit of the legal framework that Latinos are facing. So when the prior administration came in, they created all the work around the wall and all that stuff. But then they did another thing, which essentially, it was not a law, it was a regulation. But if you actually used money that came from the federal government for food stamps or for Medicaid or for whatever, you got put at the end of the line in the immigration line. And it ended up, if I get any help, you know how these things happen. They start being very specific and then they grow in the community. So we were seeing people die at home, citizens die at home because, their wife was in the line to get their citizenship. And if they got to the hospital, maybe they would lose the citizenship. So we designed a hospital at home where we would monitor people at home and take care of them without them needing to access the tertiary systems. We designed a Spanish speaking information line with 9 lines. We designed a robust case management that would help people because, as you know, during the pandemic, it was not only about getting tested and vaccinated, but getting food and getting not evicted from your apartment. And what happens when you have 4 families living in a 1-bedroom apartment, which happens, and we need to isolate people. We can't, right? So all this was managed through the case management component, and then a big health promotion component, right? With 20 health promoters in the street 7 days a week, busting myths, telling people where to go, how to get help, a very successful health promotion. And then a communications campaign. And that was, with the creation of WhatsApp group. I don't know if you've looked at the data on what communication forums do different groups use. And Latinos, mostly 40% of Latinos use WhatsApp. So when you design a campaign for Latinos, you need to make sure that you include WhatsApp. There was Facebook, there was Instagram, there was Twitter, and eventually TikTok for the younger, when reaching younger crowd was important, right? And all that sat on the coordination that happened through the staff of the LHI, a data dashboard that was created through a company called Blue Novo. And also we required the help of the Primary Care Coalition to help with the financial management of the whole organization. So as you see, this is very complex and it tackles a lot of the issues around access that we had been advocating. It has to be linguistic You need to use health promotion in the community. You need to go where people are because a lot of people don't have transportation, etc., etc. So if you actually look at the blueprint that I put the link, you can look at how all these things and the design of Salud y Bienestar really match with all those things that we had spent 20 years telling people that probably they should do. Next. So a little bit of the results. The program started in August of 2020. So we have done around 100 and a little bit under 135,000 tests in the community. We have served around 17,000 individuals through the case management, as here you can see, mostly Spanish speakers. We have had 59 admissions to the hospital at home. And as I said, we have 9 full-time information lines that provide information in Spanish. Next. So if you don't mind, I hope you can hear. This is part of the communication campaign. She's Abuelina. And let's see if we can watch the video to get a sense of the campaign.
Hola, soy la abuelina y vivo en el condado de Montgomery. Mascarilla, gel desinfectante, las llaves y listo. Al salir de casa hay que protegerse y guardar distancia, que no te alcance el COVID. ¿Ya te hiciste la prueba? Yo a eso voy. ¿No sabes dónde? Tranquilo, yo te ayudo. Llama al 301-270-8432 porque nuestra salud y bienestar son lo primero en el hogar.
So you can see there like a ton of
Hola, soy la abuelina y vivo en el condado.
And and actually this campaign won an Emmy on its category for its innovative. This was based on a lot of work with focus groups and a lot of feedback from the community. So how does Montgomery County look today? So more than 95% of the population in Montgomery County has received at least 1 dose of the vaccine. 88% have received both doses, so they're fully vaccinated. And then 54%, and this falls a little bit, have received booster or additional dosing. If you see the rates of first vaccination in children are actually quite high too. And if you see in the county, Latinos and Asians are the most vaccinated ethnicities in the county. The bottom one is the vaccination of children, and the other one is adults, and this graph I think ends up in November. But again, you see we started behind. The Latinos were the ones that were getting less vaccinated in the beginning. Access, always access. But when we did what I've described, right? We went to where they were. We told them when they called where to go. The case managements made sure that they were connected. We are not the first. Asians do better, generally speaking, but we have done really well in vaccinating Latinos in our county. Next. So I want to spend a moment to tell you what I have learned with this project, right? And then if you want to ask questions or we can talk about it. So the first thing is, don't get lost in the shining star. Nothing is easy. You're not going to design a really functional initiative just using one thing, right? A year ago or 2 years ago, the fashion was the novelas. Let's do novelas for Latinos, right? Because there was one study that was published and showed how good novelas were. But the reality is that there's no easy ticket, right? When Abuelina campaign won an Emmy, everybody was like, oh, we need to implement Abuelina campaign and everything will be perfect. No, Abuelina was just one of many things that happened to make this a success story. So if someone tries to sell you something that's one intervention and that it will solve the world for you, just don't buy it, because it's not going to happen, right? The other thing is like, oh, wow, you were able to design this over a weekend. And I'm like, a weekend and 20 years? Because this is not done overnight. The relationships of trust within the community are not done overnight. If you're committed to make equality happen, you need to commit to a community and keep at it. And there'll be really, really difficult times, but you just need to keep at it, because eventually you'll be there at the right time. You know, we were applying for a grant and they were telling me, oh, how come you know all these people? I'm like, I just show up. You know, even when there's nothing for me to gain, I just show up. So this idea of showing up, partnering, being there for the community will help you actually accomplish what you set out to do. Public-private partnerships, they work if, okay, there's no one single individual that has the power in that relationship. A lot of times what I see is that people talk about public-private partnerships, but all the power sits in one and the other has no voice, and those don't work. You need to make sure that when you establish that kind of partnership, the voice of the community is heard. And sometimes it's uncomfortable because we do things in a way that doesn't make, like, let me give you an example. For instance, in the beginning, we were using medical assistants to test and vaccinate. And they're like, no, you need to use licensed nurses. And we're like, no, there are not enough licensed nurses that speak Spanish. I'm going to use a medical assistant that was a nurse in her country, and it's an intramuscular shot. So we had to spend 2 months arguing about this until the state issued a regulation that said, yes, it was okay. So you will face this discomfort with the way that you do things, and that's okay, so long as everybody has a voice, right? And then make things add up. What I mean with that is that it's not about you alone. It's how many people come to the table and how we can all together do things. If you go into public health to be known and to, you know, be that person, the Fauci of the next generation, it's not going to happen. You need to make sure you adapt, and that you adapt with others, so that ultimately we accomplish our goals, which is we have a community that doesn't have to struggle so much to just survive. So I'm going to shut up now, and I'm going to allow questions to come, or thoughts or ideas, or, you know, oh, I was thinking about that when you were talking, kind of thing.
Thank you so much, Dr. Izquierdo Pereira. I do have one question in the chat that stated, these are fantastic, referencing the video that was nominated for the Emmy. What software did you use to create those videos? They were really well done.
I don't know. This is actually, this was done by Communication Shop. They actually are a professional advertising company. They use whatever, I don't know, you know, we were not part of the group that made them created them. But also, it's not only the graphics, it's also the amount of work that went into creating these. These were based on a significant amount of focus groups, asking people, you know, what are you hearing? What are your questions? So I would encourage you to go into the website. I think I put a link somewhere. And if not, just go to Por Nuestra Salud y Bienestar and you'll find it, and look at the videos. But bear in mind that they have been created with a lot of work in the background to support the elements that they had. So I'm sorry I could not ask the question of the software. I don't know.
Perfect. You mentioned that you use focus groups to kind of, I guess, focus on how to best reach people. Other than focus groups, what other methods did you use in this campaign to make sure you reach the your target audience?
Yeah, so to be clear, the communication campaign was carried not by me, but Communication Shop. But what they did a lot is, for instance, we did a lot of Facebook Lives. And, I was part of a number of them. And people would be able to ask questions. And if questions that came up in the Facebook Lives were quite frequent, then they would grab those questions and put it in the design of the next communication. So again, this was a whole work done by professionals of the communication world. I can tell you how we went about doing things in the community and, showing up at the supermarkets and the churches and how we made everybody comfortable with these things. But they are the ones that really designed this communication campaign.
Okay, one last question from me.
Yeah.
How did you start building the partnerships with the organizations that you partnered with?
So the majority of the organizations were part of the steering committee. So we've known each other for many years. We've gone to the county council to advocate for money for Latino projects. We've gone and, just when you live in the same community, you end up showing up at the same events when you take care of Latinos, and they end up inviting you. I am the only Latino geriatrician in the whole county, right? So I end up getting invited as the token Latino to many things. And then you end up seeing the same people, right? Over and over again. That's what I was trying to say. Just show up, right? Sometimes you'll get invited to things. You're not gonna win anything. There's nothing particularly important for you to do in there. But if someone is asking you, just show up. First you may just help that person, and why not, right? But then you never know, you keep knowing people and meeting people, and you end up having this sort of network of relationships, right? And you have a network of relationship. Your friend that leads another organization has another network of relationship that sometimes superposes with yours, but not always. And you end up having a very strong network of relationships that can be brought to bear in a time of crisis, right? I can call certain people on the phone, like, hey, I have people that are hungry. And, oh, don't worry, we'll bring the food to their home, right? So, but that didn't happen when I was in my previous job, the medical director of the Spanish Catholic Center, and I started attending. I didn't know anybody, I just started attending because someone asked me. And I think this just showing up, even if there's nothing obvious that you can gain, is a very important piece of building a network that can support equity in the long run.
That was really insightful. Thank you so much. I appreciate that.
Of course.
Does anyone else have any other questions?
It's not a question, but just a comment. Such a great work. Thank you so much for sharing with us. But you eloquently mentioned about how just showing up is such a great way of engaging stakeholders. And I'm wondering if the model, the framework that you have presented is we can scale it up and adapt it to other preventative chronic diseases, not only COVID. Do you think that's doable?
Of course. And, you know, I was asked to just talk 15 minutes, so I didn't go in depth into the Latino Health Initiative work for 20 years. But for instance, there's a whole work around asthma, right? And, you know, people that live in very unhealthy conditions and keep having asthma, they have a whole other component, you know, around chronic conditions. But one thing that I think has been different with our sister African American program is that the African American health program has focused on disease-based issues, right? Except for maternal mortality, which is more a systems-based issue. They tend to focus more on disease specific, right? They have the diabetes program, they have more chronic condition programs, whereas the Latino Health Initiative tends to have more system-based programs. For instance, we have the Welcome Back Center, which essentially helps providers and any health professional really that got trained in other countries. And this is not exclusively for Latinos. Any provider or health professional trained in a foreign country that want to do the steps to be able to practice here. And what that does is it brings minorities into the healthcare system, right? So a system base. Then they have I'm having a senior moment giving the reunification program, right? It's about children that have been away from their parents for 15, 10, 12 years. And when they come to a different country, they come to a different environment, and they don't even recognize their parents, right? So all the work that goes around reunification that has to do with social work, but also with education and mental health. So we tend to have more system-based programs, whereas the African American health program tends to have more disease-specific programs. Now, I honestly think that when you impact system and you change systems, it impacts chronic diseases. But let me tell you a story of a guy I used to take care of. This very nice guy. I generally take care of elders, but if they have a family member that's above 19 and needs healthcare, we'll do it as part of a cluster family. So this guy was 19 years old and super healthy, was going to college, playing lacrosse, good weight, no cholesterol, no sugar, no nothing. So, okay, I'll see you next year for your physical. I see him come back next year. He's gained 50 pounds, has high cholesterol, has diabetes. And I'm like, what happened? And he's like, my car broke. I'm like, connect the dots for me. I'm confused. He's like, my car broke. So I could not go to college. So I had to drop the lacrosse. I no longer can get an education. We don't have money for healthy food. So we just eat beans and rice, which is what we can afford. And I live in a neighborhood that's not safe. So I cannot exercise, right? So if you go into this case, for instance, and try to treat the diabetes, yes, I can give medication. But unless I have a systems-based approach, there's very little that you can do in such frail environments where a car breaking down really screws the rest. Because essentially this guy in a year lost 20 years of his life. His life expectancy became 20 years less because his car broke down and they could not buy a new car or repair the old one, right? So I think as you think about disease specific, I'm not saying it's not a good thing. I mean, each community has to design what works for each community. But don't forget that there's a whole underpinning of social determinants of health that are gonna limit your ability to just focus on one thing, no, on eating healthy. Okay, well, if I focus on eating healthy in this example I gave you, I need to figure out about food insecurity, and then I need to figure out about transportation, and then I need to figure out about neighborhood safety. And you see, so anyway, that was a phenomenally long answer to tell you that yes, you can adapt, and we actually have some chronic disease programs. We have a smoking cessation program, but that we focus a lot on system-based change because it does impact those other things a lot. So sorry, I chat a lot, but thank you for those questions. Is there anyone else that has another question? Okay.
Okay, thank you so much for answering our questions. We're going to move on to the next presentation. I'm going to turn it over to Jalesia.
Hi, everyone.
Hello.
Sorry, in my office. I'm trying to adjust on. Is my camera on? Can you guys hear me?
Yes.
Okay.
I can see you.
Okay. I don't know what's going on my screen. Okay. So I wanted to talk a little bit about kind of moving forward past COVID-19 and what we've seen, the changes that we've seen that I hope continue and that, we kind of plan to continue in healthcare so that we are having equity for all. So my name is Jalesia Green. I am a first year MPH student at Benedictine. I'm also an interoperative neurophysiologist at the University of Chicago, and I'm the director of education for Dro Health, which is a medical company in Nigeria, where I'm teaching neurophysiology there. I got my undergrad from Miami University, and I am currently pre-PA. I'm applying to PA school in like 2 weeks. And then my interests are mainly preventive healthcare in urban populations, health inequity, and social determinants of health. So I just wanted to touch on health equity. I know that we've been talking about it all week, but I just want to say advancing health equity relies upon understanding the central role of social determinants of health and influencing individuals' contexts, options, and behaviors, and thus their whole health outcome. And I think a lot of people talk about equality versus equity, and I know we've all probably seen a similar figure to this one over the past few years. But equality is that we all have the same rights and resources, and we all have the same standard of care. That is what equality is supposed to mean, but equity is more about the individual level. So we all have the same rights and the same resources, or the rights to the same resources and the same standard of care, technically, but equity recognizes that every person has in their own individual circumstance and that they might need some resources allocated separately to them so that they can be equal with everyone else. And the ramifications of inequities, like high mortality rate, we're obviously going to have more social problems, higher crime rates, worse overall health, more education inequalities are some of the major ramifications of inequities. But overall, as a society, when we are all equal and all equitable together, everyone lives a happier, healthier, longer life. So some of the big changes that we kind of we saw starting during COVID and a little bit before COVID, but really take off is digital health. So telehealth, medical devices, mobile applications, even texting, we saw that really advanced during COVID. So telehealth visits were obviously very big. I work at a hospital, and as the millennial in the group, I basically had to go around and help all of my doctors set up iPads and teach them how to use Zoom and teach them how to schedule and kind of see their schedule, and then help the administrators figure out how to schedule the Zoom appointments. It was a big change, but it ended up working out really well. Not only were they able to see the patients they had been seeing, but they were able to add additional patients who kind of lived farther away or for whatever reason would have had trouble getting into the hospital for the regular appointments. People who often miss appointments that they were supposed to have were now making their appointments. I remember shadowing a few appointments where people were literally just, we had a woman on her lunch break from the nursing home, and she just sat in her car. And so she had her appointment. She was able to talk about whatever issue she had, get her medications refilled, something that is really hard for a lot of people just due to their daily busy life. Even now, using phones, some hospitals administered phones to their physicians and their various clinicians. And they're now able to just a text and shoot a quick email back to their patients, which is really shortening their day. Okay, we also have mobile apps and digital health monitoring. So we've had apps like MyChart and ZocDoc previously, but they really advanced them during COVID. MyChart, for if your health system is using it, when they started advancing MyChart, now you can get your COVID vaccine there. You can request prescription refills, request appointments. You can see all your vaccines, your whole medical history. You can see your lab results. So it's really taken off as far as being able to manage your own health, and right there from your phone or right there from your laptop. Additionally, we have these really cool apps like these diabetes apps. I read an article a while back about a doctor whose mother during COVID, she was all alone, diabetes type 2. So they downloaded this diabetes app, and it was able to connect with her doctor, but it's also a little social network for people in a similar position she is in. So they shared recipes. She monitored her eating every day. She logged everything, and her doctor could see it and stay on track. So that really helped her overall health. And after only 3 months, she was dropped from diabetes down to pre-stage. So that's pretty major, and it's literally allowing a person to put their health in their own hands. And we have the advancement of medical devices, and not just medical devices like your Apple Watch, but FDA approved devices. So Whoop, which I actually have one of these, is a FDA approved wearable, and you wear it 24/7 with exception of being in the shower. When you charge it, you actually put the charger piece on top of your Whoop so you don't take it off. And you're able just to keep track of how well you're sleeping, how much energy you're burning. And then you can use the information it's giving you to kind of titrate how you live your life so that you are being more efficient and you feel better. AliveCore and Fitbit Sense. So Fitbit Sense is a new one. It's an app that's going to be downloaded on the Fitbit, and that is basically able to run like an EKG and alert for AFib. So is the Zeo patch. So those are going to connect directly back with your clinician, and then they can look at all the data and they can see what's going on with your heart. And so that's pretty major when we're talking about not having to come in for an extended stay in the hospital, which is incredibly expensive, to run an EKG test for several days. Now you can just strap it on your chest or strap it on your wrist and go about your day. And things like this are covered with the insurance. And that's it. Yeah. Thanks. All right. And then the benefits of digital health. They're going to give patients more control over their own health. They give clinicians a better overview of their patient's overall health. And it's been shown to actually reduce cost, but also improve the accuracy of the diagnosis, which is pretty major. So there are several studies showing that given this full picture, clinicians are able to accurately diagnose more often. And obviously, the big one is that it's going to improve access to healthcare. So you have people in the rural areas, or maybe even an urban area, but no transportation for, or unable to leave home, unable to get to the doctor's office for whatever reason. Having these digital health options is going to make a huge difference for people like that. And then next we have the formation of the super clinics. So the super clinics are what we're calling those CVS minute clinics. I think Walmart has a type, and Walgreens as well. So those clinics that you find in your grocery store and your drugstore and your just your regular supermarket stores. So they really, really increase health equity access. When we talk about preventative medicine, vaccines, just small acute care issues, and then health and fitness checks, those can be placed anywhere. So you're not going to drop a giant hospital system in Southern Illinois, rural, anywhere. They might have to drive 45 minutes to the closest hospital for something as small as their yearly checkup. So that's going to discourage people from going, which means they're not getting their labs drawn. They aren't getting their blood pressure checked. And if they have anything going on where they feel a little off, they're more likely just going to get used to it and kind of shove it down and ignore it instead of getting it checked out. So these super clinics and having them at your local grocery store where you have to go every week anyway, really will improve access for everyone and health equity. And last, we have supply chain. So I'm sure you guys all know about the major supply chain issue we had here in the United States, well, and all over the world with COVID-19 and PPE. So paper products were just not turning out as quick as we needed them to. And because we outsourced nearly everything, we were just unable to keep up with the demand, and we were unable to be picked first because, you know, we were coming next to whatever countries we were getting our supply from. This is still an ongoing issue. Every day I come to work and we're out of some major drugs. So epi and fentanyl and several other drugs we're kind of rotating through being low on, and then we have them again that we're low on. Various paper products that we use in surgery, same thing. So being able to form local supply chains is going to help improve health equity, but also it's going to help build jobs and help the community itself. So some Chicago hospitals have been, big hospital systems have been talking about building their own supply chain network here in the city to cover a lot of these costs. It's going to reduce costs, right? Because we're not paying international fees, we're not paying international tax and tariffs, all that good stuff. But also, it's a quick access to supplies. It's going to be more reliable. And like I said, it's going to create jobs. So overall, some of the things that we're going to see, or hopefully we're going to continue to push forward, are advancement of digital health, creation of the super clinics, and control of supply chain. Any questions? It's okay if you don't have any questions.
I don't have a specific question, just more of a comment. I wasn't aware, I live in the Chicagoland area, so I wasn't aware of the, I guess, desire to create supply chains within this area, but I think that's a really, really great idea, just to, like you said, create more jobs and then make sure that we have access to the supplies that we need in the healthcare field.
Yeah, I read a couple articles about it, and I've been seeing them over the past year. I don't know if it's for sure happening, and it didn't say exactly what hospital systems, but there has been talk. So hopefully something like that does happen, because that would be major.
Does anyone else have any questions or comments? Okay, if not, thank you so much, Jalicia. That was a great presentation. Thank you for sharing about ways that we can move forward in advancing health equity in public health. So yeah, we just wanted to say thank you all for attending today, as well as attending all the different days of our conference. We especially want to thank our speakers for this tonight, Mona, Dr. Izquierda Pereira, and Jalicia. Thank you so much. We truly, truly appreciate you taking the time to create these presentations and to share a little bit of your wisdom and knowledge with us. And that would conclude our conference for this week. Thank you again.